All right, we're at the top of the hour at 2 o'clock. I want to welcome you to the course, a session for the prescriber, the Macy Catheter in the Hospice and Palliative Setting, presented by Bradford Macy. Brad is a 25-year veteran hospice nurse and the president of HospiCorp. For the majority of his career as a hospice nurse, Mr. Macy cared for home hospice patients in the after-hours setting, covering 3 counties in the San Francisco Bay Area, where he saw thousands of difficult symptom management cases. Out of a need to better manage symptoms quickly in the home setting with medications readily at bedside, Mr. Macy invented the Macy Catheter. This catheter is designed to administer fluids and medications rectally. Mr. Macy has presented and educated on issues related to the end of life and symptom management both nationally and internationally over the last decade. During this time, Brad has contributed to the research in the field, including publications in the Journal of Pain and Symptom Management and the Journal of Hospice and Palliative Nursing. It is now my great pleasure to introduce to you Bradford Macy.
Thank you, Tabitha. So today I'm going to review what the Macy catheter is for those of you who haven't had a lot of experience with it, when and why the Macy catheter is utilized in hospice, comparative effectiveness and comfort studies, pharmacology of rectally delivered medications, and then I'm going to have Dr. Wendy Schmitz go over some medications and case studies. I think hearing from a prescriber who is an expert at using this catheter will be very helpful. Cost and quality information, and then the Macy catheter. I'm going to show a video of a nurse, long-term hospice nurse, that took care of her brother as a closing about the why the Macy catheter is becoming more popular in hospice as a device. So Tabitha mentioned I was a hospice nurse and I cared for patients after hours in the home setting. And what I found in my practice was 80% of the time, sublingual medicines worked very well, but that 20% of the time, sublingual medication ended up causing either delay in symptoms, no symptom control at all, or even some issues with aspiration. Terminal agitation, seizures, pain, or severe respiratory distress were some of the things that I found where I just didn't want to control sublingually. What the Macy catheter allows you to do is continue the medications that are already at the bedside in oral form rectally so that the nurse can get that patient comfortable immediately without having a lag time to get subcutaneous or IV or whatever else that might be needed, another route of delivery. So now there's no lag time for symptom control, and it allows for an easy, discreet, and comfortable way to administer medicine rectally, which we've really never had before. Nobody likes giving suppositories. Families don't like giving suppositories, and it demands a repeated invasion of privacy. But the catheter is placed in the rectum one time and the medicines are given ongoing. And it empowers caregivers to provide the goals of care in the setting of the patient's choice. If you see here, the medication port sits on the patient's leg. So you don't have to uncover the patient, you don't have to turn the patient, you don't even have to bother the patient in any way at all to give medication. The FDA indication for the catheter is to provide rectal access to administer liquids and medications. And we can hydrate via the catheter. I'm not going to go into a lot of detail about that, but it is included in the policy and procedure that we provide agencies. It's called proctoclysis, and it's a comfortable procedure that can administer enough fluid to a patient in the setting of that patient's choice safely to keep that patient hydrated for whatever goal of end-of-life goal the patient may have, or for whatever clinical reason. You need an MD or a nurse practitioner order to use the catheter, and it can remain in place for up to 28 days. That means if a patient has a bowel movement, the catheter is simply expelled with the bowel movement. So the catheter is designed with a semi-retention balloon, which means it's retained unless a patient has to have a bowel movement, in which case it's expelled. At that point, the catheter can be wiped off and reinserted for up to 28 days. So a new catheter is not needed. It's not going into a sterile orifice. So it's simply wiped off, cleaned, and replaced in the rectum for up to 28 days. It's a non-sterile placement, and initial placements by a nurse with reinsertion can be done by a patient or caregiver if they're teachable and willing. So talking about using the Macy catheter in the home setting, a lot of agencies like to set protocols for use, and this is what most agencies settle on. The Macy catheter is used a lot of times for any severe symptoms that come up without going to sublingual. So we don't stop at sublingual and try that first for severe symptoms, because we end up symptom chasing and aspirating and stuff like that. And then prior to resorting to parenteral or suppository, because again, in the home setting, you can get that patient comfortable without having to have anything delivered to the home. And then for mild to moderate symptoms, when oral and sublingual medications fail. So we always try oral and sublingual first with mild to moderate symptoms. But if the patient is still struggling with moderate symptoms after a set time period, the talk about placing a Macy catheter begins. And we say, maybe the patient's not absorbing medication at all from the gut. Maybe the gut is moving so slow that medication is just sitting in the stomach and we need another route of delivery. When oral dosage forms or volumes are too large, and this was something I saw a lot, because usually I was called out when symptom suffering was severe. So I would see patients on very large doses of opioids and trying to get those opioids all under the tongue, 3 or 4 mLs of morphine, 20 milligrams per ml, was too large. It wasn't absorbable under the tongue. And if, like I said, if the patient's gut was swollen, even if they swallowed it, it wouldn't work. So a lot of times they ended up aspirating it. And then when necessary medications are not absorbed sublingually, or meds needed that are known to be undeliverable via the sublingual route are needed, such as dexamethasone, seizure medicines, non-steroidal anti-inflammatories, etc. So we've talked about the Macy catheter in the home setting. Let's talk about the Macy catheter in the inpatient setting. But inpatient settings are now adopting the Macy catheter for a few reasons. We've had parenteral drug shortages in the past, which have forced the hand of several IPUs to adopt the Macy catheter as a first-line alternative. And what they found was that it works more effectively more of the time than subcutaneous. And one of the reasons for that, one of the big reasons for that, is that at the end of life, when patients are dying, their blood pressure drops. And when their blood pressure drops, the blood flow to the subcutaneous space is cut off a lot of times. And so what you have is you're delivering drug to that reservoir, but it's not getting into the central venous circulation. On the other hand, the rectal circulation is maintained even at the end of life. So even when the blood pressure drops, you still have circulation to the rectal mucosa. And why do we know that? Because of temperature. We can take a rectal temperature at the very end of life, and we can still get a core body temperature because the perfusion is still occurring in that area. It's also known to be more comfortable than parenteral, and it's easier setup, maintenance, and drug disposal. This is shown on some studies that I'll show you later. It also provides an immediate and effective discharge plan, and I think that's really important because CMS does want to see that when a patient's brought into an IPU setting, that the IPU is from the very minute their patient arrives, that they're thinking about discharge. And it can be added into your policies and procedures is, yes, they have a Macy catheter, that's our discharge plan. If this patient can go home, they're going home with the Macy catheter. Lastly, it's more cost effective than sub-Q or IV. No pumps, no IVs, no disposal and wasting of parenteral medications. So just in general, it's less expensive. One of the biggest questions agencies ask is, if I use the Macy catheter, can I bill GIP services if I use the Macy catheter when I can use the Macy catheter in the home setting? And the answer is absolutely. CMS does not care what route of delivery a medication is administered into. Their concern is that care cannot be effectively given to that patient without the 24-hour monitoring that they get with nursing staff and with physicians available, to answer and titrate medication. So it has nothing to do with the route of delivery. IVs and sub-Q can be given in the home setting too. So the second thing is that actually the Macy catheter can enhance the ability to meet CMS standards. There's 4 standards under 418, which is the CMS standard for IPU. The first one is a home-like atmosphere, and the Macy catheter provides a more home-like atmosphere versus parenteral because it's discreet and hidden. So there's no needles, there's no pumps, there's no IVs, and so it preserves the dignity, comfort, and privacy of patients better than parenteral. Next is infection control, and that's pretty obvious. It decreases the risk of bloodborne infections because you're not using needles. The next one would be environment free of hazards. And again, needle sticks to patients, family, and caregivers can occur. And this obviously decreases the risk of needle sticks or other needle-related patient injuries. Lastly is disaster preparedness plan. And the Macy catheter is in the policy and procedure that we have and we provide agencies. There is a disaster preparedness, the Macy catheter is included in that plan. And the reason is the Macy catheter can provide hydration and medication during shortages, during lack of access to deliveries of parenteral medications, and even during severe power outages when you can't run pumps and you're just using bottled water. You can literally hydrate with bottled water with the Macy catheter. So now I'd like to show a short video from Ohio's Hospice of Dayton. They switched to the Macy catheter. They have a IPU that sees over 1,500 patients a year and several thousand home patients a year. And they switched over to the Macy catheter due to parenteral drug shortage back in 2018. They Vice President of Medical Services, the Chief of Pharmacy, and the Director of Education talk in this video.
One of the big things that we've been facing recently are the national drug shortages, especially of all the injectable opioids. So when we were faced with that challenge, one of the routes that came up was using the rectal route. And of course, anytime you talk about the rectal route, there's an understandably reluctance to want to use it. It's an invasion of privacy. Any medication that's given the rectal route has to be done so repeatedly, so it's a repeated invasion of privacy. Suppositories are not comfortable to give. They can cause trauma, and they have to be given correctly.
The Macy catheter offers a comfortable and discreet way to administer medications while still maintaining the dignity of the patient, by allowing medications to be given without repositioning the patient or repeatedly invading the patient's privacy.
Because of the national shortage, we didn't have many options, so that's when we really started to investigate the Macy catheter more thoroughly. And at which point, like our injectable usage, we were not going to be able to sustain that. That's when we brought the Macy catheter folks in and learned about it and gave it a shot. And from there, it's been amazing.
We function on the level of a hospital here. And I didn't realize there was something better than what we were already using. This is a whole new level of practice, and I will never go back to the practice that I had before. And I just cannot emphasize enough. I can get people comfortable. I can keep people comfortable. I'm not accelerating medicine. I'm not adding medicine. You get the Macy in, you give them medicine, they're comfortable, and that's it. Less cost, less waste, not having to poke them, not having to maintain a peripheral IV, not having to use subcutaneous injections. You put in the Macy, you have excellent absorption, you have excellent patient comfort.
We now have a tool that we can pull out, we can insert, we can give medications without having to stick people. Families and patients don't like needles. And this is not a needle, and it's very comfortable. I haven't had any patient that seemed like it's disturbed them at all. Most of the time they don't seem to even notice that we've put it in.
Even the nurses that were the holdouts, I talked with one nurse this week just preparing for this conversation and said, hey, tell me what your thoughts are. She says, I wanted to hate it. I didn't want to like it, and I love it. And the nurses are on board.
This is a catheter I would use with my own family. I would put this in my mom without a second thought.
So that's Ohio's Hospice of Dayton. And what they did is they wanted to, after a year after they started using it, the nurses and the doctors were all saying, this is working really well. We think it's working better than subcutaneous. So they wanted to do a quality study and gather some evidence. It wasn't direct evidence, it was indirect, because they asked the nurses their opinions about what they thought was better. So what they found, they sent out a survey to all the nurses and got 191 nurse responses, which is a good sample size. And with a lot of experience with the Macy catheter, more than 40 of them had placed more than 50 Macy catheters. And what they did is they wanted to look at sublingual and subcutaneous versus the Macy catheter. And they wanted to look at effectiveness and comfort versus the Macy catheter. So the first question was to ask, when I have a patient with severe symptoms requiring timely medication management, the Macy catheter compared to sublingual medication is, and 78% answered more effective than sublingual medications, and another 20% answered equally as effective as sublingual medications, with only 1.5% saying less effective. In terms of comfort of sublingual medications, and I thought this was an interesting one, 69 or 70% of the nurses said that the Macy catheter is more comfortable than sublingual medications. And why would that be? Usually we think about sublingual is so easy, it's so comfortable, it doesn't hurt the patient, but the Macy catheter is only placed once, and then the patient never knows they're even getting medication and they're never bothered. Whereas with sublingual, the patient has to be repeatedly bothered. The oral cavity has to be, opened, and stuff has to be squirted in there. So I suspect what the nurses felt in their experience was the Macy catheter is completely comfortable to place, and then the patient never knows they're getting medication. Another 26% said that it was equally as comfortable for the patient as sublingual. In terms of subcutaneous, if we look at that, again, same questions. When a patient I'm caring for has severe symptoms requiring timely medication management, the Macy catheter, when compared to subcutaneous medication, is, and more than half of the nurses answered more effective than giving subcutaneous injections. Another 40% said equally as effective. So more than 90% of nurses felt that it's more equally or more effective than giving subcutaneous injections. And then in terms of comfort, of course, this isn't really a surprise. 82% of nurses felt that it's more comfortable than subcutaneous medications, with another 15% saying it's equally as comfortable for the patient as subcutaneous. The last question they asked, which I thought was interesting because of the signal, you get 97.5% of nurses, was that if I were asked by a family member or a friend of a family member in hospice whether they should consider the Macy catheter for symptom management, I would say the Macy catheter works for symptom management, or the Macy catheter works, but I recommend subcutaneous injections or IV for symptom management. So 97.5% would recommend the Macy catheter and not recommend subcutaneous or IV symptom management. And I think that says a lot. So let's talk a little bit about rectal physiology. Back to Physiology 101, it's a good absorptive surface area with a high percentage of absorptive cells, but it's also a very dry surface area. So the rectal mucosa actually needs about 10 to 15 mLs of free water to dissolve a tablet or a suppository or a water-soluble suppository. So most of the medicines that we use at the end of life actually work better in what we call micro-enema form versus suppository. It's like a dry sponge. Our patients are already dehydrated. They're on a lot of anticholinergics and opioids. So that mucosa is really dry, and it's not really in much condition to give to find free water to dissolve tablets or suppositories. So really, it acts like a dry sponge. The other thing that happens is there's a little bit of increased bioavailability because this very distal third of the rectum, as you can see here, there's at least partial bypass from the liver here. It dumps directly into the inferior vena cava. Versatility, medication versatility via the rectal route is very high, with at least one drug, if not several, within each of these classes that can be absorbed rectally. Basically, all of your opioids, most of your NSAIDs, benzodiazepines, antiemetics, anticonvulsants, etc., can be given this way. It's versatile. It's the most versatile route next to the oral route. Let's take a little bit of a deeper dive into comparative rectal pharmacokinetics. So if we look at some of the studies that have done, ME here is micro-enema. And if we look at morphine, oral versus micro-enema, the bioavailability is the same as oral, but there was significant pain relief in 10 minutes versus oral, which was 60 minutes. So you get a really much quicker onset of action with pain intensity control continued by the rectal route at 3 hours. Methadone, oral versus micro-enema, bioavailability is close to oral, 88%, with a Tmax is halved. So the time to maximum concentration in the bloodstream only takes 1.4 hours rectally versus 2.8 hours orally. So again, that translates to more rapid symptom management. It took 10 minutes versus 60 minutes oral. The phenobarbital suppository versus micro-enema, this is a medication that I studied. I got a grant to study it because it's the first drug that I gave via the method, the Macy method. And I wanted to know, I saw an incredibly rapid control of terminal agitation using it, 15 minutes, and the patient was comfortable and calm. And I kept on doing, the repeated, it kept on repeating itself, and other nurses were finding it. So I really wanted to understand, can we show this in blood levels? And we were able to demonstrate it. What we did is we compared micro-enema to suppository for phenobarbital. And we found that phenobarbital blood levels were 12 times higher at 30 minutes versus micro-enema, for micro-enema compared to suppository. And that those concentrations achieved in 30 minutes took via the micro-enema took 4 hours to achieve by suppository. So again, with terminal agitation, we don't want to wait 4 hours to control that terminal agitation. We want to get that terminal agitation controlled in 30 minutes. Variability between subjects was also much less with the micro-enema versus suppository. And this is interesting, and it's something that we'll find, I'll show you, that micro-enema variability is really low with micro-enema, which means, you know, we don't have the intrasubject variability. So 2 suppositories in our study actually failed completely. And these were young, healthy volunteers in this study. It was a triple-arm study, not elderly, dehydrated patients with a lot of stool in their rectum. So I thought that was an interesting thing to find. Quetiapine, Seroquel, rectal versus oral. Now this study was done not with micro-enema, it was a suppository they prepared, and they found rectal bioavailability was 189% compared to oral. So it is a dose adjustment. You want to cut the dose by about 50% if you're switching from oral to rectal. Tmax was comparable for both routes, but the variability was for rectal versus oral was less. As I pointed out with phenobarb, you can see it was only 20 minutes plus or minus rectally versus more than an hour, 68 minutes plus or minus orally. Lorazepam, this was 2 studies that looked at lorazepam, oral, sublingual, and then IM and micro-enema. You can see here that Tmax was about 1.1 hours for the micro-enema versus the same for IM, for intramuscular, 1.15, and then it was twice as long for oral and twice as long for sublingual. So, you know, again, clinically, this has important aspects when we're trying to give sublingual lorazepam and it doesn't seem to be working, and we've got severe agitation or anxiety. Macy catheter and or a micro-enema dosing could be a much quicker way. Looking at diazepam, this is a well-known drug for speed rectally with a Tmax of 17 minutes. That's lightning fast via micro-enema. And notice here, it took 82 minutes via suppository. So again, there's the difference in speed. And again, this was done with healthy volunteers and not elderly dehydrated hospice patients. And so you've got 52 minutes orally and 95 minutes IM. So again, micro-enema wins in terms of speed and also in terms of variability. The intrasubject variability was lowest for the micro-enema and highest orally. This medication reference I'm just going to show you. We have, if you're interested in it, you can send us an email and ask for it. It shows the event, the medication that's indicated for the event, the bioavailability, and then the reference, okay, and pharmacy notes for it. And it covers delirium, seizures, fever, nausea, vomiting, fluid replacement, fluid overload, pain, agitation, and all of that. Now I'd like to have Dr. Schmitz talk to you about her experience with the Macy catheter and let her talk about the medications she uses and give some case studies because they're really quite exceptional case studies.
Medications that are not appropriate for the Macy catheter. Anything that cannot be crushed, anything that's long-acting, PPIs, Prilosec that comes in the beads, those can't go through that area. Long-acting meds like Toprol XL can't go through that. Keppra, the liquid can, but the tablets cannot be crushed, so they can't go through. Medications that are not recommended due to inadequate levels, Neurontin, Triliptal, glycopyrrolate, baclofen, Dilantin. And I don't know that these are specifically that it's going to cause them harm. as much as it is that the levels have been inadequate as compared to oral routes. The NIOSH precautions, I think if you're in hospice, you've probably been hearing in regards to this, specifically medications for safe handling. And for our population, the 5 medicines that I am not using, that I am not crushing. So I am not changing the formulation that comes from the factory on these 5 medicines. So whether that's giving, you know, I'm not crushing diflucan to give it orally. I'm not crushing it to give it rectally. Anything, you know, I would use diflucan liquid, elixir, but the volume in that is significant. And so typically if you can't swallow a pill whole and you still need diflucan, we're giving it IV. Valproic acid is another big one. It can be used as an elixir through the Macy catheter, but I'm not crushing those tablets to give rectally because of the NIOSH precautions and recommendations. The other one that I would not give rectally would be potassium, and I have not had experience in that somebody has been uncomfortable with it, but typically that would not be a medicine. I think that the risks of irritation to the colon would be a significant possibility, so I've not done that. So any comfort medication, I should back up a little. So I am not writing, make all of the oral medications oral or rectal. My goal is that this, at this point in this juncture, is an opportunity for families specifically to hear your loved one is not doing well. Your loved one is declining. They're no longer able to swallow. We're going to change our route. We're going to change our meds. We're going to make things simpler. We're going to focus on comfort. And so really my goal through meds, through the Macy catheter, are primarily comfort driven. So definitely opioids, benzos, antipsychotics, absolutely. Antihypertensives, I definitely use. And especially clonidine, that's probably one of the most common, although Lasix from a volume perspective is excellent. Digoxin, I've had no troubles. Decadron, absolutely. We talked about Keppra elixir. Valium is wonderful. Phenobarbital, and especially phenobarbital and Seroquel, are an amazing combination for folks who are terminally agitated. Levsin, you know, I have not had good effects from Levsin being given sublingually for terminal congestion, but rectally it is very, very good. But that's, it can be used for antibiotics. I typically don't use it for antibiotics, but if I have a family that is insistent that their loved one have antibiotics, I have definitely given antibiotics via the Macy catheter. Sinemet, I think if there is one medicine from a Parkinsonian perspective that is going to change their outcome, is Sinemet. So I usually, in my Parkinson's patients, I usually continue the short-acting Sinemet. Amiodarone, I've had families that just like stopping it was not an option, but its half-life is like forever. So the likelihood that someone's going to survive through, you know, and not be covered by the amiodarone they've stopped taking is pretty small. So I typically don't use amiodarone, but I have in some circumstances. Beta blockers I use regularly. ACE inhibitors I use regularly. Lactulose is no problem. Trazodone is no problem. Synthroid, again, the half-life for Synthroid is so long that it doesn't need to be given, but there are some patients and families that just have a hard time letting things go, and so sometimes it's kind of that middle ground that we negotiate on. Rectal hydration, and I had a couple of questions in regards to this, so I'm going to spend a few minutes here. The studies that have been done, not by me, but the studies that I've seen have shown that 400 cc's an hour can be given and tolerated rectally, which is phenomenal. I have never used that much. The most that I have ever used is 250 cc's, and I have the nurses push that, and would use that every 4 hours, either for a certain period of time or every 4 hours as needed. I've had 2 patients specifically that I've used this on for long periods of time. One little elderly lady who does great playing bingo and bridge, and then seems to fall off a cliff due to dehydration, has really poor vascular access, wants to be at home. Daughter is a nurse, and so when she's dehydrated and not doing well, the daughter just places the Macy, gives her some hydration, and she bounces right back up and goes back to her normal daily activities. I have a case study at the end of this presentation where I talk about a young lady that I used pretty regular basis for PR hydration. She had gastric and bowel issues chronically, was not able to absorb, really had a frozen abdomen, and we put in a Macy catheter, would use hydration as she needed it, and she actually was discharged from hospice with her Macy catheter for rectal hydration. Mr. B, 28-year-old drug addict, he was down at the University of Cincinnati and was called to see whether or not we would take him on our unit. And drug addict, endocarditis, septic, infected glomerular nephritis, increasing pain in his right leg, and found to have had an embolic phenomenon to the right leg. Lactic acid was 6.4, his white count was 50,000. He had been intubated, aggressive antibiotics, and no improvement. He underwent Wulst. His leg was cold, pulseless, and any exam, repositioning, touching led to significant agitation, and he was 121 pounds. At the hospital, he was on Ativan, 37.5 milligrams of Ativan an hour. That is not a typo. 37.5 milligrams of IV Ativan an hour. Like, where do you go from there? Like, you can't, more isn't working. Morphine 10 milligrams, and while he was at the hospital, he was on a Precedex drip. So the hospital, this was in July, and the new resident calls me to give me information about this young man for transfer. And they were not going to allow him to have these medications in the squad coming up the highway. And we're, at more than an hour away. And there's just nothing I could do to convince this young resident that that was the wrong thing to do. And I said, okay, well, what I want you to do is go in the guy's room, turn the meds off, and go and check on him in an hour and a half and see how he's doing. And he's like, we can't do that. It's like, no kidding, you can't do that. That's what you're asking me to do is, no meds for an hour and a half. That's ridiculous. So he came on the Ativan and the morphine, came up the freeway. When he got here, we put in the Macy catheter, started him on methadone 10 milligrams rectally every 4 hours, phenobarbital every 4, Valium every 4, and then breakthrough medications as needed. And what I asked the nurses to do was that I continued the IV Ativan and morphine. On arrival, he got a dose of meds. At 4 hours, he got a dose of meds, and we decreased his morphine and Ativan by 50%. 4 hours later, he got his 3rd dose of rectal medications, and at that time, the IV morphine and IV Ativan were stopped. And in the first 12 hours through this process, he used 2 PRN doses of rectal Roxanol, and that's all he used. And the patient passed away with us comfortably 2 days later. Case number 4 is Miss S. This is the lady who I was saying had the frozen abdomen, 28 years old, extensive medical history, Ehlers-Danlos syndrome, Arnold-Chiari syndrome, VP shunt, posterior fossa decompression. She had 10 abdominal surgeries in 4 years and now presents with a frozen bowel and colonic dysmotility. She has no surgical options. TPN was stopped. She had a Hickman catheter, but it was infected and pus was draining visibly from the site, and we were unable to obtain any further IV access. She was using her Hickman catheter, even though it had pus coming out of it. Occasionally she would tolerate oral intake, but multiple times a day, vomiting, intractable nausea, uncontrolled pain. Her home regimen, she was on dilaudid PCA at 0.4 an hour and 0.5 every hour as a PRN. She was giving herself ketamine 30 milligrams IV every 3 hours and IV Ativan 2 milligrams IV every 3 hours. And she also had a duragesic patch in place. She states that her pain was persistently a 10 out of 10. And she sets her alarm every hour to wake up to push her PCA and to self-inject her IV ketamine and IV Ativan. And she also has a latex allergy. Macy catheter is silicone. There is no latex. We were able to use it for this young lady. Placed a rectal catheter, started her on methadone 5 milligrams every 8 and stopped her IV dilaudid drip after her second dose of methadone. Removed her duragesic patch, started her on ketamine 30 every 8 and Valium 2.5 to 5 rectally every 8. And this is one of the young ladies that I had on long-term fluid, where she could just, when she was dehydrated every 4 hours, she could just push 200 cc's of tap water. Also had other comfort meds that I was using for her. Zantac, we can use rectally. Any of the H2 blockers can be used rectally. Naproxen or ibuprofen can be used rectally. Trazodone can be used. Zyprexa. Prilosec, I don't, especially the ones with the beads. They're given rectally. I don't crush this. And then she had a scopolamine patch on as well. She lives at home with friends that support her. And we're able to train the caregivers as well as the patient how to manage her meds. So all of her meds were ordered orally or rectally, so she could take them orally if she felt up to it, but she could also give them rectally if need be. And this young lady, like I said, she was 28. This young lady was literally going to social events, going on vacation, driving her car, and we eventually discharged her from hospice with a Macy catheter for volume and medications as she needed, and got her back to life. A couple more cases that I think are interesting. This young lady is 62, had a very large neuroendocrine tumor that was had bulky intra-abdominal lymphadenopathy and a huge mass with a gastric outlet obstruction and persistent nausea and vomiting. She was on methadone 10 milligrams every 8 hours, but she was unable to tolerate it and couldn't keep anything down and presented to us in a pain crisis. Has a history of a DVT with a PE, is on Lovenox and an IVC filter, and she also has high blood pressure. So we converted her methadone, same. She was taking 10 orally. Here we're giving 10 rectally every 8 hours. I used Toradol 30 milligrams every 8 hours for 3 doses and then converted her over to Naproxen 500 milligrams every 12 through her Macy catheter. Haldol we were using for nausea, clonidine for her blood pressure, and she had an NG to low intermittent wall suction. So she was awake, alert, eating, anything that would be able to go through the NG, and then medications were being given rectally. She had been in the inpatient unit for 10 days and then requested to get her Keytruda. She was on a grant that had already been delivered, was in her name. And so she went to the oncologist who agreed to give her Keytruda. She got it and unfortunately was not effective, and she passed away 2 weeks later in our inpatient unit.
So that was Dr. Wendy Schmitz. If you'd like to see the rest of her webinar, it is on our website at macycatheter.com under webinars. I believe she has at least 3 other case studies that she shows. So let's go into bowel meds really quickly. We've reviewed palliative medications, but you can also do bowel care with the Macy catheter, and it can enhance bowel care because it can provide retention enema. And lactulose, sometimes patients can't hold lactulose long enough to allow it to provide good bowel care. So you would instill the lactulose with the patient on the left side and have them hold it for 30 minutes. Some prescribers will add water to the lactulose, which tends to put it across more of the surface area of the descending colon and whatnot. Remove the catheter when the patient's ready to expel the bowel movement, and then replace the catheter after bowel movement. For Dulcolax, it's nice because you can add a little bit of water to the Dulcolax. Like I said, in a dry rectum, sometimes the medication doesn't dissolve enough or break down enough to stimulate the motility needed. So Dulcolax, you can add 20 mLs maybe of water, 10 or 20 mLs of water. Have the patient hold until they have an urge to defecate. Remove the catheter, or if the patient's incontinent, the catheter will be expelled with a bowel movement. Fleet's phosphate enemas and saline enemas can be given the same way by simply putting the enema into an parenteral syringe and injecting the enema through the Macy catheter that way. Reglan is absorbed systemically, so it's well absorbed rectally, and you would give it just the way you would give any other medications that are going to be absorbed systemically. They'll be absorbed in the distal third of the colon. Add 10 mLs of water to ground tablets, and then flush with 3 mLs. The do not gives via the Macy catheter would be Fleet's oil enemas. That's going to be too thick, the oil via the catheter. But you can give the enema to the side of the Macy catheter with the Macy catheter in place, or take the catheter out, whatever you wish to do. But the catheter will act as a retention enema. So you may want to just give the oil enema, have the patient hold it for, for as long as needed, and then take the catheter out, and they can have a bowel movement. Senecot should not be given at all. It's a vegetable laxative, and it expands quite rapidly when it's wetted. I can't imagine how many G-tubes have been clogged that way. The mechanism of the action is also such that it doesn't work in the rectum. The mechanism of action is in the colon. Milk of magnesia, same thing, mechanism of action is in the colon, so it's not going to be effective given rectally. Cost effectiveness and quality of care. So Hospice Buffalo did a study in 2017 they looked at their IPU savings. They also looked at their home savings, or the system of home care with the Macy catheter. They were able to figure out exactly how much they saved in the IPU, not as much in the home, but they did figure they had savings. So in the IPU, they used 230 catheters. That was about 50% of their IPU patients at that time, for a total agency savings of $94,000, or $401 per catheter used. In the home setting, they found that they were able to decrease the amount of time that nurses were out at the home setting. They found that a lot of times patients with severe symptoms could take several hours to control symptoms. So they were able to decrease the number of hours nurses were in the field, and also decrease the delivery charges. They also were able to decrease the amount of time that patients had symptom managements waiting for medications to arrive to the home setting. So basically, they found that the rectal administration catheter has improved the ability of Hospice Buffalo to facilitate quick and effective symptom management while simultaneously decreasing costs and improving nursing efficiency. This is also on our website under references. We have on our website, we have studies and references. So next I'm going to show a video of a nurse that as a hospice nurse for 16 years, and she took care of her brother in hospice.
When I'm talking to you now, I'm talking to you from two different completely perspectives. First, I'm talking to you as a nurse and having experienced what I've just gone through. And secondly, I'm talking to you as a family member who was given the final authority to make all medical decisions on behalf of my brother who was dying with cancer. His pain management was very tricky. He was on very high doses of medication such as methadone, oxycodone, lorazepam, and these things to keep him comfortable. So the first initial thing was to give him oral meds. So we started in on giving him liquid methadone, liquid oxycodone, and liquid lorazepam. And as the time progressed throughout the day, we kept dosing him up, and we were giving it to him sublingually. We were giving such large doses of liquids that I wasn't feeling so comfortable with it. I decided to pick up my stethoscope as the nursing side of me, and I put it to his chest. And when I listened and heard what was going on in the chest, I just nearly dropped to the ground, because the first thought that came to me now on the clinical side of it is, oh my gosh, we're dosing him with such large amounts of liquid medication that he's aspirating it. He's taking it down his lungs. And the last thing I wanted with my brother was to see him die of aspiration. I wanted him to be comfortable. I didn't want him choking on all the medication we were giving him. That caused a tremendous amount of grief. And my nurse, my fellow nurse, who was not there at the time because of the COVID crisis, had left the Macy catheter in the home already. We turned him, I inserted the catheter, and I was able to give the medications via the catheter and lay him back on his back and get him comfortable. And when I saw the difference in how that medication was going in and the difference in him physiologically, he finally just began to just be even more calmer. The first thing I thought to myself is, why did I wait so long? And I'll tell you what happened. A couple doses of medication through that catheter, and he passed within the hour. Which told me, gee, my goodness, probably should have done this way, way sooner, and would have wrestled a lot less with what caused me a lot of guilt thereafter. And the guilt was, with my loved one, those lungs were filling up, and I would question my clinical experience after 16 years of hospice. Why haven't I used this catheter sooner? Which then brings me to the next question. How many of those patients have truly aspirated over the years in those final hours versus just really died because of the disease process? I'm not saying the disease process didn't cause the death, but what I mean more importantly is how much aspiration could possibly have occurred over all these years of not using this catheter. And that has me concerned because, as we've all heard, aspiration, getting that fluid into your lungs and dying that way, is definitely not a good way to go.
So, as we know, and from Deanna's experience with her brother, it leaves a lasting impression when a patient dies comfortably or when they die uncomfortably. And it obviously is going to affect their life, and it's going to affect also quality scores. So I did look at quality scores. I looked at the Hospice Compare, and I looked at the bottom box scores for pain and symptom management. So for agencies that use the Macy catheter in different numbers, 10% of their annual patients, 20% of their annual, and 30% of their annual patients. And I compared it to the national average in San Francisco Bay Area agencies that we're not using. So the question is, the patients sometimes or never got the help they needed. So the first thing I noticed is that 1 in 10 families feel that hospice did not give them the pain and symptom management necessary. And I think hospices can do better in general. And I know that the issue here is that for patients that die uncomfortably, where the hospice is simply not able to get in control of those symptoms. We're chasing symptoms for a long time, and then, or the patient dies very uncomfortably. The chances of a family filling out a negative CAP score is much higher. On the flip side, for agencies that are able to get in when a patient starts to have bad symptoms and get those symptoms under control immediately, it's more likely that that family is going to fill out a positive CAP score because the agency literally saved the day. So I think that's part of what's playing here. And as you can see, for every 10% increase in utilization of the Macy catheter, there was a 10%, basically a 10% decrease in the percentage of families that reported super low bottom box scores. The San Francisco Bay Area's agencies not using, most of the hospices in the San Francisco Bay Area use the Macy catheter. So I wanted to pick, I couldn't look at all hospices throughout the country not using. So I compared just to that one area. So that's the end. And now I'd like to turn it over to a Q&A session. Thank you. Tabitha?
Brad, we do have a question from Michael Tobin. The question is, if using rectal hydration, does one have to alter how they are administering medications rectally?
That's a really good question. And my recommendation as a clinician would be to wait about 30 minutes after hydration. That'll give the rectum time to, the colon time to absorb that fluid, or give the medicine about 30 minutes before the infusion. So I'd give it 30 minutes.
Got one more question. If a patient has constipation, is it necessary to evacuate the rectum before placing the catheter?
That's a really good question, and I didn't go into it. So yes and no. And the reason I say that is if a patient is severely impacted, where, you know, when you go to place the catheter, you actually feel stool blocking the catheter going in, I would recommend at least disimpacting a few inches of stool. Now, I know in my practice, when patients were really uncomfortable and they had a lot of symptoms going on and they were close to the end of life, I didn't really like doing a serious disimpaction procedure. So I would recommend removing a few inches of the stool, enough to get the balloon placed in the rectum. The other thing that does is it takes the pressure off of the internal rectal sphincter, and it might help with pain or agitation just to remove severe impaction. So it does not inhibit absorption of the medication, or at least to any, I can say that with, you know, anecdotally, it is not, stool in the rectum has not seemed to affect symptom management with the Macy catheter.
Okay, our time is up then.
All right, thank you everybody. And I hope you watch Dr. Schmitz's webinar on our website. It really is a phenomenal webinar. Thank you so much.
Have a great day.